In the third and final part of this talk, I'll speak a bit about hemorrhage and vascular malformations in children. As I mentioned in part 2, hemorrhage accounts for about 45% of stroke in children. And most of the time, cause can be identified. Of course, there are hemorrhages that are due to trauma, traumatic brain injury, but I'll be speaking mostly about hemorrhages that are non-traumatic in origin. Of these, by far the most common cause is a vascular malformation. So at least a third and up to half of hemorrhage in children is caused by a vascular malformation. There are other causes that are rare, including bleeding diatheses, venous thrombosis, intracranial tumors, arteriopathies, and use of certain drugs, particularly amphetamines and cocaine. Arterial hypertension is often present in children with hemorrhage, but it's usually not the sole cause. When a child presents with symptoms that are thought to possibly be due to intracranial hemorrhage, such as thunderclap headache, or focal neurologic symptoms, such as hemiparesis or seizures, the initial evaluation is by magnetic resonance imaging or computed tomography. And both of these methods are quite sensitive for hemorrhage. So unlike ischemic stroke, where magnetic resonance imaging is more likely to be sensitive for a lesion, in hemorrhage, computed tomography can show an acute lesion with high reliability. Because most hemorrhage in children is caused by vascular malformations, it's important to consider angiography to look for an underlying vascular malformation, as well as venography to look for venous thrombosis, which can cause hemorrhage. Almost all children with hemorrhage without an identifiable non-vascular cause should end up undergoing catheter angiography. And that, again, is because of the high prevalence of vascular malformations. So if a vascular malformation is not seen on MRI or CT, it's important still to pursue catheter angiogram because some small vascular malformations may be missed by these techniques. Conversely, if an MRI or CT does show the presence of a vascular malformation, catheter angiography is often still indicated, sometimes for embolization for definitive treatment, at other times for better characterization of the lesion for potential surgical resection. But from a laboratory perspective, it's important to make sure that the hemorrhage is not exacerbated by thrombocytopenia or by a coagulopathy. If you've undergone a complete evaluation for structural causes, so if you've done non-invasive imaging and catheter angiography and still haven't found the source of hemorrhage, then a further, more extensive evaluation for bleeding diatheses could be considered. As I mentioned in passing, venous sinus thrombosis is a cause of hemorrhage that should be thought about in children, especially in the neonatal period, but also in older children. It typically presents with seizures, headache, sometimes with symptoms of increased intracranial pressure and focal neurologic dysfunction. And often on physical exam, papilledema is present. There are a number of risk factors for venous sinus thrombosis in children, including dehydration, hypoxia, local infection, such as meningitis, sinusitis, or otitis media, systemic illnesses such as diabetes, inflammatory bowel disease, lupus, other rheumatologic diseases, and chronic anemia, and other prothrombotic states. On computed tomography, you might see the hemorrhage associated with venous sinus thrombosis, as I mentioned earlier, and you might see signs of the sinus thrombosis itself. So on an unenhanced CT, sometimes you're able to observe linear densities in the cortical veins or in the sinuses themselves. In CT with intravenous contrast, sometimes you can observe filling defects in the dural sinuses that correspond to the thrombi. Magnetic resonance imaging is sensitive for acute and subacute thrombosis as well as associated hemorrhage. And if you can perform MR venography, this may also demonstrate the venous occlusion. Here's an example of a 2.5-month-old boy who presented with poor feeding and failure to thrive. And on the T2 star weighted MRI image, what you can see are these linear areas of signal hypointensity within the deep medullary veins, as well as relatively discrete areas of periventricular hemorrhage with a rim of surrounding ischemia. And this is due to fairly extensive thrombosis of the medullary venous system. This child was treated with anticoagulation, but on a follow-up scan 6 months later, you can see that these areas where there has been venous ischemia and hemorrhage have progressed to cystic encephalomalacia. This is another case of a 14-year-old girl in Yemen who presented to a hospital there with hemiparesis and ophthalmoplegia. She underwent both enhanced and unenhanced CT. And in this case, the pertinent findings are thrombosis of the internal jugular vein on the left. You can see that there's evidence of a filling defect within the internal jugular vein. But there's also more extensive thrombosis of the intracranial sinuses. So I'll call your attention to the cavernous sinus and the superior petrosal sinus. You can see that there's normal filling and enhancement of the cavernous and superior petrosal sinuses on the right. But on the left, these areas don't fill with contrast and are, by comparison, hypodense. This child also had evidence of preseptal cellulitis with swelling and erythema of the orbital region and the left side of the face. And the CT incidentally demonstrates inflammation in almost all of the sinuses. So there's evidence of pansinusitis on CT, which probably provoked the thrombosis. In cases of non-septic thrombosis, we often recommend anticoagulation, even in the presence of hemorrhage. And this is an important point because the hemorrhage is caused by venous congestion and rupture of small veins. Really the risk of extension of the hemorrhage with anticoagulation is present, but lower than the risk of propagation of thrombus, which could worsen the hemorrhage due to venous congestion. In septic thrombosis, because the underlying cause is inflammation due to infection, we often avoid anticoagulation. In that case, we treat with antibiotics. Anticoagulation with intercurrent infection may be associated with a higher bleeding risk. So that, for that reason, it's relatively controversial. But when it does involve structures such as the cavernous sinus, we sometimes do anticoagulate, and that's to prevent permanent injury to the cranial nerves. Venous sinus thrombosis is a relatively rare cause of hemorrhage in children, but it is important to think about. By contrast, arteriovenous malformations are quite a common cause of hemorrhage in children. They typically occur in the supratentorial region, but they can also occur in the posterior fossa and in the spinal cord. And most often when they present, it's because they've ruptured and cause seizures, focal neurologic deficits, or evidence of increased intracranial pressure. Of course, arteriovenous malformations can be present and may not rupture for many years. The estimated annual hemorrhage risk is variable. It depends on the characteristics of the lesion, but it ranges between a little less than 1% and 4% per year. However, it's important to recognize because when they do rupture, about 25% of these cases are fatal. Catheter angiography is the gold standard for diagnosis and characterization of arteriovenous malformations. This is an 11-year-old girl who presented with a sudden onset severe headache. And on the computed tomography image, you can see that there is a right frontoparietal hemorrhage which extends into the lateral ventricle. She underwent catheter angiography, which showed a relatively compact nidus of vessels within the left parietal lobe, and this was resected surgically with good outcome. There are a number of different potential treatments. So as in the last case we saw, these lesions can be resected surgically. Sometimes they can be embolized by intravascular means. So during a diagnostic catheter angiogram, you can sometimes treat as well by embolizing the malformation. And in some cases, when the lesion is not amenable to embolization or resection, you can treat with stereotactic radiosurgery to either to shrink the lesion or to try to eliminate some of the feeding vessels to make it more amenable to another type of therapy. The types of arterial venous malformations that are considered to be of extremely high surgical risk are those with deep venous drainage, those that are adjacent to eloquent brain, so typically the motor or somatosensory cortices on the dominant side, as well as classical language areas, and those that are relatively large, medium-sized, meaning they have a nidus of 3 to 6 centimeters, or large AVMs, which have a nidus greater than 6 centimeters. Certain types of AVMs are considered to be inoperable, and those are those with extremely large or diffuse nidus. This lesion, which was present in a 14-year-old boy who presented with headaches, was deemed to be of high surgical risk because it is adjacent to eloquent cortex on the dominant side near the in the occipital lobe near the occipitoparietal junction. It's a medium size, so the nidus is greater than 3 centimeters, and it has very prominent deep venous drainage, as you can see demonstrated here. So for this reason, the child was treated with stereotactic radiosurgery rather than resection. Another type of vascular malformation seen in children are cavernous malformations. These are low-flow lesions that consist of a cluster of thin-walled, immature blood vessels without intervening brain tissue. In contrast to arteriovenous malformations, which do usually have intervening brain tissue. They are thought to be lower risk than arteriovenous malformations of the type that I just talked about, but can present with symptomatic hemorrhage. The risk is typically less than about 1% per year. Oftentimes, however, they're discovered incidentally if a child obtains an MRI or a CT for some other reason. They can occur throughout the brain or the spinal cord, and oftentimes have a genetic risk factor. So there are several genes that are associated with hereditary cavernous malformations. They can also occur after exposure to cranial radiation. In children with sporadic cavernous malformations, about a third, between a quarter and a third, have multiple lesions, that is more than one cavernous malformation. Sometimes these lesions are accompanied by a developmental venous anomaly, another type of vascular malformation, which is thought to have a relatively low risk of rupture or symptomatic presentation. Sometimes cavernous malformations can be tricky to diagnose. So on computed tomography, you may see evidence of prior hemorrhage from a cavernous malformation, but you may not see the lesion itself. They do have a very characteristic appearance on magnetic resonance imaging. So it's described as sort of a popcorn ball appearance with evidence of blood products of varying ages and a rim of hemosiderin. And this is because cavernous malformations are extremely prone to bleeding, usually in small amounts. So they rupture and bleed, but usually it's contained and doesn't cause a symptomatic hemorrhage. And so you see this appearance of a lesion with evidence of chronic blood products of varying ages. Susceptibility weighted imaging may reveal additional lesions which are very small and may not have had larger bleeds. Oftentimes, because these lesions are such low flow, you don't see them on a catheter angiogram. As I mentioned, cavernous malformations are usually incidental findings, and they're thought to have a relatively low risk of rupture. But when they do rupture, particularly in sensitive locations, they can cause severe symptoms. So this is an example of a 17-year-old girl who presented with acute onset of hemiparesis and was found to have a sort of discrete globular type hemorrhage within the pons. You can see on the FLAIR image that it's relatively round and it has this rim of hypointense signal. So this was a pontine cavernous malformation that had bled and was surgically resected. When cavernous malformations are detected incidentally, they're usually not treated, often because the risk of surgery is thought to be greater than the risk of symptomatic hemorrhage. Even when the malformations are associated with seizures, we often don't treat them unless the seizures are refractory to medical management. When a lesion does present in a location that causes severe neurologic symptoms, such as the pons, for example, or when the seizures are poorly controlled by medication, they can be treated with surgical resection or radiosurgery. Thank you for your attention.